Thanks so much, Mariah, as well as Sherry and JT and Deb. Appreciate this and excited to be sharing the space with Dr. Paget. I'm going to kick it off with UME, and then we'll hand it over to Dr. Paget to move to the GME space. Let me get this moving. So before I get started, I do want to acknowledge that several of these slides are either stolen from or developed with Dr. Gonzalo, our Senior Associate Dean for Medical Education. And just to refer back to the Teach website, which has a really comprehensive compendium of all of our presentations. Jed did a presentation on competency-based medical education back in last January, and so that's available, and you'll see several of these slides in that one as well. Many of these conversations have been had with Dr. Brock Mutchison, so much of this is, as with all of it, is work that we do in the space all the time with a number of different people. So Mariah already went through the objectives, but just as a refresher, we're going to talk about competence versus time-based curricula, and I'll get to that in a few slides. But then thinking about what this looks like in undergraduate versus graduate medical education, and then how do we actually assess competencies? What are the similarities and differences in UME, which is what I'll be saying quite a bit, and GME. So our outcomes in undergraduate medical education are what we are ultimately striving for. When we're developing our curricula, our learning experiences, our assessments, we're thinking about ultimately what do we want. And this was a slide as many of you are probably intimately familiar with, we recently restructured our phase 1 curriculum, and that will be flowing up into our phase 2 and 3 curricula here in the next couple of months. But when we were planning for our new phase 1 curriculum, this was a slide that we often use to sort of anchor ourselves in the development of everything we were doing. So when we think about phase 1, a lot of times students and some educators think, well, our top priority is to make sure that they can pass step 1. But you can see that I wrote that in much smaller font because that really is not the ultimate goal. We certainly want that, but that's the bare minimum. Our next threshold of outcomes was thinking about, we want to make sure our learners are ready for clerkships. And that really helped us think about what we wanted to include or not include as we consolidated some of our learning in phase 1. And then finally, what we wanted to really keep in mind was our VTC-SOM values, which are represented in the graphic on the right of that slide. And at the center of that is the patient-centered physician. And then surrounding it are the identities that have really been at the heart of VTC-SOM since its foundation, and now encapsulated in this graphic with master adaptive learner, scientist physician, and systems citizen. So these are identities that we want to be thinking about even as we're developing a curriculum for our brand new first year medical students. And that's really the heart of competency-based medical education, is focusing on the professional identity that we're striving for. That's really our North Star. But in order to get there, we need the competencies underneath to build up towards that identity. So this is, on the right is Miller's pyramid with an extra box at the top that was added in this Cruis and Cruis model pyramid for competencies and professional identity development. So again, what we're striving for at the end of the day is having a graduate who can consistently demonstrate attitudes, values, and behaviors expected of one who has come to think, act, and feel like a patient-centered physician. But underneath that, we have to describe what makes that up. So those are the competencies, and you can see sort of the foundation at the bottom with knowledge, and then moving up that pyramid to knowing how and showing how and doing. And competency-based medical education is really thinking deeply about what are these competencies, how do we describe and define them, and then how do we measure them on this path towards identity formation. So medical education is filled with all sorts of acronyms and this is a slide that sort of summarizes those. But at the top of this list is entrustable professional activities, and Dr. Paget's going to talk quite a bit about those. So that's in that red over on the left side of this diagram. But built into those are domains of competence, sort of categories of competencies that capture a specific dimension. Underneath that are competencies or actions that someone performs or demonstrates within the practice environment. And then to define each of those competencies, we need specific observable and measurable achievements or milestones that show the development of that learner's competence. On the far right of this figure, you can see our narrative descriptions. As faculty are assessing learners, they are providing feedback, and often that feedback touches on a number of different competencies. And so teasing apart what is relevant to a given competency from that narrative description is an important part of assessing and providing feedback for a learner. So when we think about this continuum of ultimately a patient-centered physician who's an expert, we want to think about medical education as something that begins in medical school and then progresses throughout one's career. So over on the left, we see medical school really where learners enter and they're not allowed to practice, they're novices, but by the time they finish medical school, they've become advanced and they can practice with full supervision. And that's the handoff point into the GME space. And during those residency and fellowship programs, those learners, those trainees are becoming competent and able to first practice with supervision on call, and then ultimately without supervision. And then there's this phase of learning where a professional becomes an expert. And so ideally, this is a continuum, and there's these handoffs that happen from one stage of learning to another, and there's not sort of a disjunction, and there's continuity. And so that's what we're always working to get towards. And to do this, I want to start with what you see on the left here, these ACGME core competencies. So graduate medical education about 20 years ago, or a little over that, established these competency domains that you can see in blue around that hexagon. And they describe different areas of development. And in undergraduate medical education, we haven't had that sort of a solidified framework to build from. But using the GME core competencies, last year or 2 years ago, when VTCSOM underwent our medical education strategic planning process, we built our educational program objectives intentionally aligned with the ACGME core competencies to provide this continuity of learning. There's been work since then, not since then, but there's been ongoing work in the undergraduate medical education space to come up with a similar framework for GME in the UME space. You can see this report shown here, the foundational competencies for undergraduate medical education. It was work done organized by AAMC with ACGME input and ACOM input to come up with a similar framework, because we need, if this is going to be a continuum, there needs to be similarity from UME to GME. Fortunately, our EPOs are very much in line with what is recommended. These aren't mandatory for medical schools yet, but more like guidelines to help shape curricula. But they do align with the ACGME core competencies. So as we think about competencies in medical school and undergraduate medical education, it is important that they be vertically integrated, so that what we're doing on day one of medical school is providing a platform to build on by the time a learner graduates. And so how do we do that? Here is a really busy graphic showing all of our phases. So in yellow, you can see phase 1, and then moving into phase 2, clerkships in the burgundy, and then finally phase 3, career exploration. Ideally, what we're doing is we're scaffolding in phase 1 the medical knowledge and skills and other competencies that allow handoff into phase 2 and then ultimately into phase 3. That's what we mean when we say vertical integration. And I think that it's we often think of phase one as really being that medical knowledge foundation base. And to build on that in phase two and three, rather than leaving that behind, what we're doing with our class of 2028 as they progress into phase two, we will have these landing spots and intersessions shown here in those gold spots for some of that medical knowledge to be vertically integrated up into the clerkships. There's a lot of other plans for those intersessions, as some of you, I think, on the call know, who've been helping plan for those. And this is something that, working closely with Aubrey Knight as phase two director and Christy Stewart as phase three director, Jed is helping us ensure that we've got this vertically integrated space within these intersessions. But the higher order competencies, and we'll talk about harmonized milestones in a minute, are also important to begin vertically integrating and not just waiting until the clerkship phase or phase three to be thinking about some of these less knowledge-based competencies. So this is a quick segue or quick stop about thinking about competency-based medical education versus time. So when we think about the ideal version of what competency-based medical education would be, it really would be thinking about when a learner has achieved competence in a specific area, then they're ready to progress. And so if they met all of their milestones, then we would move them straight into residency. But we all know right now, medical education is either 3 in some cases, but usually 4 years. And so it's fairly time driven. So how do we reconcile the idea of a very time bounded curriculum with the philosophy of competence development? And some of the ways we're doing that in undergraduate medical education is thinking about an individual learner and helping them identify where they need to focus to develop competence. So one of the things we've baked into our new curriculum is frequent low stakes assessments rather than a single high stakes assessment that doesn't allow time for those micro adjustments that we would want on the path towards competency development. Developing personalized learning plans. So right now in semester 2 of phase 1, Dr. Carvalho and Dr. Schmidt-Dalton are busy developing learning plans when students have gaps in their medical knowledge or their clinical skill sets, developing a plan that helps a specific learner identify what they need to be working on and some additional work that can help support that. We have a coaching program that supports our learners to identify their own gaps in knowledge. This is to really provide that scaffolding so that as a student becomes comfortable with identifying their gaps and how to fill in those gaps, when they move into phase 2, 3, or residency, or even into professional practice, they can be focused on developing their own competence rather than relying on external assessments to guide them. So these are some of the ways we bring the principles of CBME into UME, even though we have a 4-year hard time stop for how long it takes. And then one last way we've been thinking about doing this is we've shortened phase 1 and really expanded phase 3, that post-clerkship phase, to allow for more personalized learning, so that instead of ending clerkships at the end of right before 4th year begins, now students in the class of 2028 and beyond will be beginning that phase 3 curriculum in February. And that allows for some personalization of learning throughout the last several months of medical school, which is, again, another hallmark of competency-based medical education, is this idea of tailoring one's path towards what is most needed. So in order to assess competence, we need milestones. And I think it's often easiest to think about this in something a little more concrete, like providing an oral presentation of a clinical encounter. And so providing those descriptions that allow us to determine where a learner is along this developmental phase can look something like this, where a novice is someone who understands the core components of a case presentation, and then an advanced beginner delivers a presentation. It might not be concise, it might wander a little bit. A competent learner along this competency domain or competency might be delivering a presentation that's organized around a chief concern. And then proficient might be integrating pertinent positives and negatives. And finally, the expert is able to filter, synthesize, prioritize information into a concise and well-organized presentation. So you can see each of these descriptors allows us to provide feedback for a learner about where they are. But that dotted line shows that this is not just a straight out arrow. Once a learner hits novice, they are at that time point. You can see if we just did one assessment at this point in this dip, but that this learner experiences here, we might not be giving them adequate feedback about where they really are. And this speaks to the need for those sort of low stakes, frequent assessments, because in order to move towards competence, a learner needs to be observed and then assessed and then coached. And it's this cycle. And so this frequent feedback, moving a learner towards proficiency, is an important part of competency-based medical education. And a big difference between UME and GME is that this assessment phase is not overseen specifically by what we see in GME as a clinical competency committee. Sometimes in the clerkships, there's something that looks a little bit like that, but this is really in the UME space up to each individual faculty member to be providing feedback so that a learner can move through this continuum. And that's why frequent feedback, making sure we're all on the same page about what a milestone means, it requires a lot of teamwork so that we can be giving what a learner needs in order to be working towards competence. So where this can get a little more challenging is in some of the competencies that are not either medical knowledge based or patient care skills based. So that brings us to this idea of harmonized milestones, which is a phrase that is used most frequently in the GME space. So if we go back to those ACGME core competencies, you can see I mentioned patient care and medical knowledge are some of those areas that are a little more readily or regularly assessed. But these other 4 competency domains, systems-based practice, professionalism, interpersonal communication skills, practice-based learning and improvement, those are all a little less readily assessed, if you will, and yet they are common across all specialties. So in ACGME, these patient care and medical knowledge competencies, you'll hear Dr. Paget talk specifically about what this looks like for surgery. But these competencies, these other 4 competencies, make up what are called the harmonized milestones. They're common across all residency programs. And so we have those, of course, baked into our EPOs, our educational program objectives and sub-competencies. And bringing assessment of those into phase 1 has really been something that we've focused on for the past couple of years with all of our phase 1 educators. So in UME, those are these milestones that span all learning settings, whether you're in research and inquiry or integrated foundational sciences. These are skills and behaviors that you can assess and exhibit no matter where you are. And they're really critical for preparing a learner for clerkship and for that identity formation that I talked about at the beginning. And so the way we've done this, preliminarily at least, is thinking about things like interprofessional and team communication in the pre-clerkship phase, commitment to personal growth and reflective practice, accountability and conscientious behavior, which falls into the practice-based learning and improvement competency domain. And the way we're doing this is breaking it down into those milestones that we can actually give feedback on. So attendance and timely completion of assignments and attention to course details, if we're looking at this accountability and conscientious behavior competency. And so what does that look like? Well, we have an assessment form that all of our course directors are responsible for filling out, and they're able to look at this milestone and say, Okay, if I'm asking whether a student is demonstrating conscientious behavior, maybe they're arriving late and they're not attending all the required events, but they are demonstrating some conscientious behavior by reaching out and communicating that they weren't able to make it, and they're being proactive about it, and they're finding out what they need to do to make up whatever they missed. So we're capturing these sorts of assessments. These are formative cumulative assessments. They're released with semester grades. They allow us to illustrate some growth across the competencies. So maybe in the first semester, a learner is struggling with that proactive communication, but over time, they're getting better about doing it. It also allows us to capture comments from faculty on these milestones and not just the negative ones. We're able to let a learner know that we see that they're being really good about paying attention to course expectations, and that they're the ones who come in prepared and ready to jump into a learning experience. This also helps us inform learning plans and coaching discussions and remediation, because if a learner isn't doing well in the medical knowledge competency domain, sometimes that's intimately linked with how they're doing in the conscientious behavior area. So if they're not coming to class, or they're not making up the work that they need to make up, it's good to have this documented to be able to have a conversation about how that is influencing their ability to achieve competence in the medical knowledge area. I can't talk about our harmonized milestones without at least showing one of these spider plots. So Brock would be hopefully very excited to see this up here. What we hope to see over the course of several semesters and throughout phase 2 and 3 is that this blue pattern fills out towards the perimeter as a learner approaches competency across all of these different areas. We can visually see that they're marching through the milestones. So along this accountability and conscientious behavior path, we would see from semester 1 to 2 to 3, this sort of filling out. So this is, I'm going to hand it over to Dr. Paget in just a minute, because what we want to be thinking about is developing competence across the continuum, UME to GME, and ultimately to professional practice. And I think aligning our harmonized milestone assessments with assessments that are happening in the clinical learning environment and clerkships begin to build a foundation for what is going on in GME. Another point I wanted to bring us back to is that when we think about Miller's pyramid, that knows how, shows how, and does, those higher order competencies are harder to assess, but they're really essential. And that brings us really back to our identity formation for the patient-centered physician. And then finally, one of the competencies that I think is a real strength at VTCSOM that we're seeing a lot of interest in is this idea of systems thinking, which is in the third pillar of medical education, health system science. It's really this linking domain. And we're beginning to help our learners with that from day one. Even though it's a challenging and complicated set of skills, it's really critical to our system's citizen identity and the patient-centered physician. So I think next week, we have a workshop that looks a lot like what we do with our students, and hope any of you who are interested can come to that, because that helps make more concrete how we can assess some competencies that can be a little more difficult. So with that, I'm going to stop sharing and hand it over to Dr. Paget.
Thank you, Dr. LeConte. And actually, I'm really happy with yours, because it makes mine easier to present now. And there's a couple slides I can probably skip. Hey, so first of all, two acknowledgments to American Board of Surgery, who's been doing a lot of the heavy lifting in the last couple of years, and a lot of my slides are coming from. And probably more importantly, the Society for Improving Medical Professional Learning, which is awkward because they're trying to get it to simple, which has been doing the work behind this, the theoretical work behind it, and the actual practical work to bring us to something we can use. As a disclosure, I am a part of the advisory board for the Simple Learning which is a nonprofit, which I do not get paid for, but is basically a labor of love to try to figure out how we measure first initially surgery residents. It's actually branched out to a lot of other specialties. So,
Real quick, Dr. Paget,
pardon, oh,
you're sharing your notes
okay,
slides.
let me try that again. Stop sharing. Hey, how's that?
Perfect.
Perfect. All right. Thank you.
Thank you, JT. So here's a couple major themes that I'm going to try to discuss. Our present methods are bad and have been bad and are not gotten better in a while. They are in general retrospective, which tends to have bias introduced. They're reductionist, and in the end, they often just go back to expert opinion rather than having something more robust. The next part is what are EPAs and how are we using them to evaluate surgery residents? What are work-based assessments? And that is essentially what we are using. And we're using it both to define the spectrum of general surgery and competence, and how we can use a group of EPAs to assess a resident's competence for independent practice. So up till now, and still, we are a time-limited program. We are at minimum 5 clinical years. During that time, there's some other notes you have to accomplish. 850 cases, 250 have to be in the last year. There's both what they call a qualifying or written exam and an oral certifying exam. And most importantly, goes back to it's essentially your endorsement by your program director that you're competent. That is the actual most important thing within there. Again, this is anecdotal and back to expert opinion, and probably doesn't correlate across programs as well as we would like. The big change, and why I'm talking about this and not one of the other program directors, is surgery's been the first one that decided to go all in on entrustable professional activities, such as the entering class last year, have all been measured by EPAs. And this is a huge project and still in its infancy. And I would not say that it's even close to where we need to be. The current system that Dr. Lacan has spoken about is essentially time-based. The middle line is what we expected everyone to do, to just kind of go at the same rate and everybody will get there. And that's just not true. If anybody has worked with residents, students, not everyone follows the same path. What we are looking is a goal-based one, a fixed outcome, so that we've defined a minimum for what a practicing general surgeon can do. Milestones have been around for the last decade. They are helpful, but hard to do. They suffer from the same problems. How we assign these are often retrospective, based on what our memory was, and not necessarily prospectively. I've showed one here that I think is probably the core of being a surgeon is, can you operate? And how do we measure technical skills? There's a second patient care one that talks about steps of an operation, but this is probably the core of the process that a very novice surgeon goes through to be able to functionally practice independently. I'm not going to go through all the different ones. Notice that we do have very good descriptors. So what is the competence of a surgeon? Is it the technical ability to perform an operation? Is it the decision-making? Probably is all of these. And also how to fail safely in integration of knowledge and experience. And this is from Tenkate. Also, by the way, this is in 2016. I think Dr. Lacan had one from Tenkate in 2020. And this also goes along with about the time that surgeons were doubting their own graduates' competence. I think that my favorite one was the title, was a invited lecture called "Why Can't Johnny Operate?" In 2009, and there have been a number of ones since are questioning whether we actually are producing surgeons in this day and age that actually can do this. So this is the problem that we're facing. We don't even believe that we are actually accomplishing what we want. The competency model, it tends to be a top-down one, and it doesn't always give us what we want. And if it's done poorly, can decrease acceptable standards and really doesn't do much for us. Here's some theory versus reality. You don't need to read all of that. This is both quotes for people, but probably the most important thing is there are 88 the general surgery defines as essential common operation and 70 essential uncommon operations, about 150 that we're supposed to be training our graduates to do on during their 5 years. Well, let's look at something. These are the 20 most common. Don't read all of those, but this is the take-home message. Only 9 operations do they do more than 20 times, and only 20 operations do they do more than 10 times. And that could be spread from their very beginning time to the later part. So it's not like they're doing anything other than a few operations a lot. They're doing a lot of operations, and sometimes they're just doing it once or twice or 0 times during their during their 5-year experience. And we expect them to be able to do this independently without supervision on their own. So that's the hard climb. Going back, looking at the technical skills again, I want you to, I've just put it up again to highlight what the words are, but this is what, on average, we look like in terms of progression through the various milestones within this patient care one. And I will refer back to this again, because this is going to look very much like another curve. So it takes usually by the end of the 4th to 5th year to get into that truly that they are firing on all cylinders and from a basic technique, a milestone. Okay, how do I measure those right now? We get in a group, we say, who has worked with this resident in the last 6 months? Okay, where do you think they are? Now, look at all the recall bias, look at all of those things. This is how we are doing it now. And this is how everyone is doing it now because they don't have a better way. Switching to simple, a work-based assessment that came up with how do you evaluate a resident after their operation. So I will show, it goes this phone. This is the tool right now that we are using. I pick out the procedure. I describe whether it's an easy, intermediate, or difficult. And now the 2 important ones that I do for a resident is I say, are they very few of them are unprepared, very few of them are exceptional. I would say I hardly ever use that, but they all fall into, most of them fall into inexperienced, intermediate, or practice ready. So this is one for a hernia repair, skip. And I can put down how they did. I'm going to say this was straightforward, limited participation, skip, and finish. That was an observation based on it. That's how long it takes to document it. We also, in addition to looking at their performance, we look at autonomy. This is very important to surgery. It's one thing for me to show them how to do it, and they do it very well, while they are being actively helped. That means go here, dissect that, grab that, pull harder. No, that's not a good stitch. That's very active. Passive is when I'm there, but I'm kind of just letting them do this. And every once in a while, maybe correcting them. And that moves on to when it's supervision only, which is what we're really trying to produce. Okay, so this is the tool we've had for about a decade. And this is what, if you look at a typical performance over time on a given resident, you can see over months, they gradually get to that practice ready one on most of their activities. But also, we have to measure autonomy at the same time. And this, you can see, show and tell means they're watching me do it, which is not ideal for teaching, but it is the lowest level. That's what we're trying to get to, is autonomy so that they are requiring supervision only. So, were there anything before simple? Yes, they were, and they were laborious. The O scale, derived from OSATs, looked something like that. Imagine trying to get an observer to fill that out on all of the operations. Well, one of the magic of simple is they found that a single value, how did they perform, worked as well as 8 values. And it was almost identical to the gold standards behind this. And how many observations do I need? Now let's think about this. Over 5 years, they progress a lot. What they look like at the beginning of their 3rd year is nothing they look like at the end of their 4th year. So how is my ability to assess them, to see if they're making progress, and to assure myself that they are actually progressing enough that I can sign their certificate at the end and put them out into the general public. So for our most common procedure, for laparoscopic cholecystectomy, 23 ratings are not needed to get a reproducible autonomy rating. If I look upon all operative cases, it's actually less. And they've concentrated on how often do we need to do this. So this is a very doable sort of amount of ratings. If we want to look for a group of undifferentiated mix of procedures, 60 ratings, and this is for the reproducible for the performance rating. So it becomes a doable number. If you look back, if you remember, we're talking somewhere about 850 to 1,000 cases they're probably doing. 850 is a minimum. If you think about that over 5 years, I should be able to get 40 ratings. And this is how they progressed. This is based on Brian George, who's done the majority of this work, has shown that the only time you start to get not nearly as much separation on these is when you get to the last couple of years. And that becomes subtle because many times the 4th years are equivalent to the 5th years. Not all of them are, but that's what that looks like. So for the most part, we get pretty good differentiation as they're producing. So back to EPAs, there are units of work a physician does that I do every day, and we can evaluate whether how they engage with the patients, how they address the medical knowledge basis. Competency are much more broad. Milestones are capable of expressing progress, but what we really need is a suite of EPAs that define a specialty. And my specialty, while you could probably put ENT surgeon here, and it would be fairly similar, this would be very different from an emergency room physician. All specialties can be described by a suite of EPAs. This looks a lot like something that we saw earlier, so I'll skip it. So for the EPAs for general surgery, they've created what they think is the core skills of a general surgeon. This person could be employed. This person could be asked to do these on any day. They try to use common conditions. They also describe the essential non-technical skills such as professionalism and communication. And they talked about management of the entirety of the disease process. So they have a pre-op, an operative, and a post-operative case on all of these issues. And these are the 18 of them. I've talked to the people that developed them. I don't think that this is going to come back as the final number. Some of them may be dropped, some of them may be added, but this is our first approximation. You have to always think about this as we move through different ideas and different measurements. These are some of the, this is sort of in the test centers where they showed overall change and improvement using these in all over 5 years. So in theory, this should be able to give us some idea. this is what my EPA for the most common operation that we do, it looks like for cholecystectomy. Notice, don't bother reading all of those. By the way, this looks overwhelming. Actually, after you've read this and done this 5 times, it's easy because I know what each of those look like in a learner. So I don't have to refer back to them each time. But in the beginning, they take a bit of time. The reason I could do that one so fast is because honestly, these are residents fall into different groups and different times where they're doing. Notice they have like MKL2 and L2. Those are all milestones these things track to, with the hope that eventually, if we have enough data on the EPAs, we will be able to pre-populate. And I think right now, 17 of the 18 milestones we have would be pre-populated from this and would actually be much more reproducible across this. And so they are looking to how these track. You would find that some of the ones of the later ones and sort of the post-operative phase would track differently, the pre-operative phase would differently. But the idea is they do go back to what we originally were measuring progress, the milestones. So my take-home messages from this is, how do we move beyond the Gestalt sort of way of evaluating our trainees and moving ahead? I imagine somebody will still need to sign their certificate, but it takes a lot off the program director that it's not just me that believes that this person is competent, that we have data to show that they are. The demands of a practicing physician are wide-ranging, have both frequent and infrequent tests. This is a way we can measure both of them. Finally, I do believe competency can be measured. And I think the simpler the data collection, the more buy-in from faculty. If you can get people to buy into it, takes 20 seconds to do an evaluation. By the way, the evaluations are also within this app-based, phone-based app, also can be done. Dictation can be done at the end so that you can get specific feedback that's outside the ramifications of the evaluation you've done. And that's also a very buy-in from learners, getting frequent feedback. The key to this is essentially what Dr. LeConte mentions as low stakes evaluations and lots of them. You can't get by with just doing this once or twice per year for all of your residents. You need multiple ones in the everyday existence in real time to get that. By the way, the original Simple app, if you didn't fill it out within 72 hours, they made the point that you were not evaluating a resident at a given time. You were evaluating what your overall opinion of the resident was. Much less accurate than actually doing it in real time. And I think the key thing that we're still going to need to work on is, what do we need to measure in these? The other things will come along as they do. So that's all I have for today. I'd be happy to take any questions.
Thanks so much, Dr. Paget. Any questions?
What type of questions do you all have for our wonderful experts here? We've got lots of experience and work done in these spaces, both in the UME and GME world.
Maybe I can ask a question or at least make an observation. Chuck, I will speak mostly in the GME world, and talking from a medical subspecialty and evaluating medical residents and medical fellows. I really think your push to make this simple and able to be done in real time is extremely important. Because one of the last things you said, I think, is exactly true. Unless you're doing this pretty much in real time on the GME side, it becomes very difficult. And to do it in real time is a challenge. The administrators don't always push out the MedHub evaluations in real time. They'll come a week or two or even 3 later. The questions that are listed in the various categories, systems-based, practice-based, knowledge, and so forth, ask for details and levels. You end up checking, I don't know, 50 boxes trying to get the level correct. It becomes very frustrating for busy physicians to do that. So I know exactly how we got to that point. So I guess my question is, both for Leslie on the UME side and Chuck on the GME side, how do we make this simpler and undo some of the complexity that we've taken years and years to build? I know that's a big question, but I do think it's an important one to get accurate evaluations.
I mean, I think from a UME standpoint, I know what Dr. Paget was mentioning with sort of real-time, very simple workplace-based assessments. That is what I know I saw Dr. Adkins on here. I don't think he's still on here, but developing those for our clerkships directors and our clerkship evaluations as well, where it's not sort of a gestalt, but it is immediate, app-based, quick, and frequent, is something that I think everybody recognizes as important.
So the boring part of my talk is always all that data about how many observations does it take and this and that. I always put that in there because I think that was really the work behind it, the validity of lots of little, and just asking them 3 questions about how people did gives you such a broad understanding of things. So I think it first of all, we needed to move away from the way we do it now. End of rotation evaluations they're just littered with bias and incorrect evaluations. So you have to just kind of and why I became part of this cooperative is they seem to have an idea about it that was different. I think somebody asked, it's actually been applied to a number of different specialties. Pediatric has looked at it. There's a simple bedside that they've come up with, so it can be. And essentially, you just have to write the things your questions and put in what constitutes this. So it could be done on a lot of different levels, but it moves away from the ideal time to do it for us is right after we scrub out and walking away or in the next 15 minutes. And that's the take-home message. And they've gotten lots of data to show that if you don't do it that way, it becomes a poor evaluation. But I think we thought more questions were better. My favorite one was they found 8 questions on the OSATs could be replaced by 1, got the same information. But rather than thinking about how do I get more detail for a given student learner, you just have to ask the question over and over again with lots of different observers. So one of the interesting things I found somewhere along the way, someone decided to try to evaluate how good a surgeon was operatively. And they found actually you could take videos of them from the operating room, show them to the public, and the public can accurately discern them. But what you need is lots of observations, not just one. And I think we tend to base our opinions on students, residents, fellows on very limited interactions, maybe a few. And what you're trying to capture is multiple small ones. And again, they become low stakes because it's not you know, you may not do well today, but in general, you're going to perform at some level. And that's probably going to be pretty accurate. So I think
Yeah.
the multiple observations is the strength of this.
Well, I applaud your effort to simplify. And the tough part is validating. So there, to just give an analogy, there's an instrument called the SF-36, a quality of life instrument. It's been validated in multiple languages over years and years. And yet it's very difficult to administer outside of a research setting. I had a colleague who said, yeah, I have an SF1. It's called How You Doing? But of course, that's not validated. So the struggle is going to be where educational theory and research meets practicality. But I really think it's critical. So thank you.
I mean, I think another piece of that is the coaching aspect, where we begin to invest some of the responsibility for learners' development within the learner themselves, so that they are aggregating data for themselves and then talking through that information with a coach who's got the designated time to do that. So those frequent assessments, bringing those together, helping the learner begin to develop those self-reflective practice habits that allow them to grow through the continuum. I see Dr. Schlupner talking about obtaining real-time assessments, very difficult. Absolutely, and indeed. And so short, frequent, and then aggregating that information for sort of longer term processing is important.
We did have a comment in the chat, but Dr. LeConte, you just addressed it from Dr. Schlupner. And then there was a question about the Simple app, Dr. Paget, but I think you've already also covered that regarding, could it be applied to non-surgical specialties? And you mentioned pediatrics potentially has used it before. So anything else about the Simple app and other specialties that might be using it?
I mean, from inside the Simple organization, suddenly they went from somebody with 3 employees to 40, and they're trying to keep up. And these are people that are doing this out of love of education. But it's an interesting to watch in the last couple of years until we've got this, because the volume has so incredibly increased. However, they are creating a simple bedside one, which would be a lot of the same skills that we look at as medical students and interns in all phases of work. So that's one of the things they're working on. The other thing I realized that I didn't mention is, so I talked a lot about why we don't want time-based learning, and people say, okay, great, the idea of time-based learning. Some people need a little bit more. Some people need the average. What about the people that excel? What do you do with them? And that's the other question. And one of the things within surgery is, if you are signed off as practice ready on, say, appendectomy, and you're a 4th or 5th year resident, they talk about practicing in place, that thing that you would be credentialed to do in your institution once you reach that. Whereas the other, you may not have achieved that in all 18 of the categories, but it actually makes some, how do you actually grant autonomy and say that this person is actually ready for practice? That is one of the things that's been brought up for people once they get to that level. I won't bother telling you of all the things that will be in the way of that, including how we credential physicians at a hospital level and being paid for by insurance. But that is the idea, is that you're trying to quit making one size fit all and adapt it to the learner as they progress to actually being a practicing physician.